Jason Atkinson. And joining me on the screen is Belen Martinez-Caro. Belen, you can pronounce your name better than I.
Martinez-Caro Aguado.
Okay, so we are both gonna help lead this data management session. So we will fly through these maybe a little faster than normal because we're a little delayed. So Belen is gonna start us off and talk about Slido.
Yeah, so you might have already seen this in some other sessions, but we are utilizing Slido, which is a really cool tool for us to make this session interactive with everybody. So one way that you can participate is to, on your phones or computers, whichever one that you have, you can go to this website, slido.com, and then it's going to ask you to join an event, and our event code is going to be the hashtag and then numbers 173673. You can also download the Slido app if that is your preference and enter, again, the same event number. So you're going to have quiz questions appear throughout the presentation that will also be shown in the slides here. So you can participate through your phones or computers by answering the questions, and we'll see the results live on the screen. So maybe we'll give people a minute, see if there's any issues with it so that you can get yourselves acquainted with the system and then enter the event code. All right, so to get us started, since we're running a little late, the objectives of this presentation are going to be to discuss how to critically think about data submission. Also making sure that while you're thinking critically, you're also going to be able to find the data submission schedule, know how to complete baseline case report form data, and know how to run delinquent data reports for your studies. I think we can go to next slide. So our first Slido question is going to be, how many years of experience do you have as a clinical research professional? All right, so it looks like we have quite a few people in the 1 to 5 years. People are still responding. Great, so most everyone is in the 1 to 5 year CRP experience, which is great. I think this session is great for anybody with all experiences. So one of the things that you want to really hone in and consider when you're doing data entry is thinking outside of the box. So to think outside the box, we want to think about the big picture. So before we dive into the specifics of how we submit data, we want to talk about why is data entry important? Why are we even entering data for these studies? So as researchers, it's our responsibility to make sure that the study is conducted ethically and honestly. The results of the study, which is the data that we enter, are used to justify the effectiveness of a treatment. Lack of this data integrity could then prove to be a disaster, as something originally thought to be safe could cause unexpected pain or death. On the other side of that, data could lead to a treatment being approved by the FDA for a certain diagnosis or indication, which is great. So when thinking outside the box, you first want to look at yourself and ask yourself, can I use critical thinking skills to find the answer that I need? If you can't, if you need to reach out to your team member, can I work with a team member or even another CRP to find the answer that I need? Thinking about reaching out to your clinical team. Can I work with a PA or NP to find the answer that I need? And then also reaching out to your treating MD or PI. Can I work with my PI to find the answer that I need? Some common issues where we run into questions pretty often are pathology reports, how to read them, where to find the information, where to find the documents that we're looking for to be able to enter the data or answer the questions that the sponsor has for the study. Something that is way before our time. Let's say you took over the study and somebody that was entering the data before you is no longer in your team. A chart or maybe a system that you don't have access to be able to get that information, or maybe to respond to monitor requests or database queries. So, you know, if we have a situation where, for example, you say you don't collect, you haven't collected a QOL for a patient, think critically and say, what are some systems that we can implement, to make sure that this isn't missed in the future? How do we resolve it now and then keep it from occurring in the future? One of the examples of critical thinking, a good example situation here is the one on the screen. So the trial excludes patients with a QTCF greater than 480 milliseconds. The patient's baseline EKG shows a QTC of 482 milliseconds, and a query is generated saying that they're ineligible. Choose the correct answer of what you would do in this situation. And again, there may be one or more answers. We'll give everybody a little time. Great. So it seems like a lot of people are saying to check the QT correction formula that was used on the source EKG. That is correct. You want to make sure that it was the QTCF result that you are looking at, because that is what the eligibility is talking about specifically. So you can look at this yourself, or maybe you can ask one of your team members if you're not sure how to find the answer. Now we're going to move on to talk about data submission schedules. So this is a tool that could be really helpful for everyone, and it's found on the Alliance website, and the link is provided here. You'll go to the member login, and you'll type in your credentials. Once you're signed in, you can hover over the ribbon where it says protocols and choose protocol listing, where you can find the different diseases. Pick your disease site. Let's say GU is the one we're working with, and then pick your specific study based on the protocols that appear. And then you'll see some information in the front page, such as contact information for the study and accrual goals, but also on the left side of that, you're going to see different links, one of which are case report form links. So if you select that, you will go to this page where it's going to show you a few different documents, one of which is the data submission schedule. A pro tip here is look at this when you're enrolling your first patient on a new study, so you can see more information about when each of the forms are due. So we'll have an example for you on the next page. This is an example of a data submission schedule for this study. You'll see that much like a study assessment event schedule for a protocol, you have on the left-hand side the form name of the forms that are going to be due. And then on the upper part of that, it's going to give you the timeline or different times when this form is going to be due. I do want to point out, though, that make sure you are populating all the forms. Some forms do get triggered when you're populating other forms, so keep that in mind when you're looking at the data submission schedule and then at your EDC. Case report forms, you can follow the same process to find the paper CRFs in the website if you'd like to take a look at what data they're asking for specifically. These are very helpful when you're new to the study or new to clinical research, and you may want to complete the data by hand on a blank paper form and make sure that you have all the data that you need, because sometimes the system might log you out, and that way you have everything ready in hand to enter it once you have figured out all the information. Another pro tip is to review the case report forms up front before you actually enroll a patient, so you can figure out and expect what the EDC or report form is going to be requesting that you enter in there. An example of this, let's say it's not really spelled out in the protocol that they're going to ask you baseline number of stools in the baseline AE form, but you've taken a look at your report forms in advance. Then you can be ready to talk the patient through that visit and making sure that we are getting the source documentation that we need to be able to enter that data entry point.
Is this where I'm taking over, Belen?
This is you, yeah.
Okay. Thank you, Belen, for sharing the first slide. So I'm gonna keep talking about data entry and go through a lot of specific forms. So first is rave access. So you'll need to be listed on your institution's roster in order to get a rave invitation for the study. You have to be listed on the roster as a data manager. You can be listed for the whole institution or just for that study. And if you've not gotten an invitation, or if you deleted that invitation, you hit decline, you can reach out to CTSU Contact and request a new rave invitation. So my tip is to do not decline the invitations. So you see on this screen on the right-hand side will be your invitations, and you'll get all these invitations you can either accept and they populate into your rave studies, or decline them and they go away. So I know at my site, a lot of times a coordinator won't be working on that study, so they'll decline it. And then 6 months later, somebody goes out or somebody transitions and we say, hey, can you help out with this study? And they're like, well, I don't have an invitation anymore, because they deleted it and we have to go through that process again. So I always just let them live over in this taskbar. And then if I ever need to work on that study, I can click accept and have access to it. So studies that you've been invited to and accepted show kind of right in the middle of the page on studies. You can click on each one of those. Then once you actually click on a patient in Rave, I just wanted to show kind of how it was set up if you haven't used iMedidata Rave before. So once you click on a patient in a study, then you can see how the forms roll out. So there's a baseline folder, and inside that baseline folder are several forms, then treatment 1, treatment 2, treatment 3, et cetera, onto an off study treatment folder, off study folder. And then once they're off study, they go to follow up. And so clinical follow up 1, 2, 3, 4, which is, it carries on from treatment there. So just kind of a general look at things, this is how they're set up. You also notice dates on the right-hand side. And so Rave calculates a due date for the next form. And so in this example, it looks like clinical follow-up 12 has been submitted, and then clinical follow-up 13 has a due date next to it. And these slides are a number of years old, but you get the idea. Rave still does this today. So it calculates that next date of contact from their previous vital status date. And so then that's what when you enter that you had contact with the patient on May 1st, 2022, data is due in 3 months, it'll say, all right, May, June, July, August 1, 2022 is when that's due. The other thing I wanted to show on this form is just the pencil at the bottom right-hand corner. So if you need to amend or edit things in Rave, each log line inside a form will have this pencil next to it. So if you click that pencil, it opens up the form and allows you to change something. So if you entered a date wrong, entered information wrong, the pencil is how you go in there to amend that form. A question? Sorry. A system-generated data query is created automatically when data entered is outside the expected parameters. True or false? Lost my clicker. True. Everyone got this. Great job. So with queries, there's data managers on the back end at Mayo for Alliance can enter queries that are very specific to something going on, or there are these automatically generated queries just where something you put in the system is either non-conformant or doesn't align properly with the parameters of the form. You'll get an automatically generated query that pops up right away. I'll do questions here in just a sec. So another Slido, how are the due dates calculated in Rave? So date of last contact, due dates do not take into consideration treatment delays or schedule changes. So it is all of the above. I mean, primarily due dates are calculated by the last date of last contact. I think I have this on the next slide. Yeah. So they don't take into consideration treatment delays or schedule changes. So if your last contact is May 1, they're scheduled in 3 weeks and then they get delayed, it's gonna show you that data is due, but in reality, this patient didn't get treated, they're going to be held a week, and so you may be a week behind. So the due dates are put there to help us and guide us into when data is due, and we definitely should use those as a tool, but we also just have to use common sense to think about if there are treatment delays, et cetera. That's not factored in. They're important because of your IPEC score. So the Institutional Performance Evaluation Committee is part of Alliance. They give each of our institutions a score twice a year. And it's kind of like a report card for our institution. I don't know if you guys are involved in those or hear about them, but you want to do well. And two of the categories are form submission timeliness and data, or form submission timeliness and query submission timeliness. And I know at our institution, some of those things on the IPEC score, we are kind of outside of our control, but this is very much in our control. So whether we're submitting our forms on time and whether we're submitting our queries on time, is something that we work really hard on so that we can get, the maximum score on our IPEC. Baseline data. So I'm going to talk about like baseline treatment, follow-up, et cetera, those type of data points and hit some of the highlights. So baseline data can be some of the most difficult to enter. We have to do disease staging, talk about prior treatments, pathology, specific data can be challenging. It's probably the largest quantity of data compared to treatment and follow-up, especially. So you'll need to enter information about baseline blood and tissue submission in RAVE. And so we'll enter this in biomes as well. I think there's a biome session right after this, but biomes doesn't communicate directly with RAVE, but it actually serves as a pretty good double check to where if I'm doing data and someone else is handling the clinic and shipping those specimens, if I get the question in RAVE of has this been submitted, what was the date, what was the specimen ID number, I can check biomes, and if it's not there, I can reach out and say, hey, was this submitted? Are you going to ship this? So it does provide kind of a double check to make sure everyone on your team is getting that pathology submitted on time. Baseline data tips. Have a coworker double check baseline data. Ask the study data manager questions if you need to. The study data manager is listed in the Alliance protocol on the front page where it lists the study chair and protocol coordinator, et cetera. So you can always ask the study data manager questions about what are you looking for here and what type of information if it needs clarification. Consult the data submission schedule to determine what might be needed, or if there's a form that's going to roll out that you're maybe not expecting, you can look at the DSS to determine what's going to be expected at baseline. And then always use the information you entered in open and on your eligibility check sheet, which we talked about in the orientation session, to kind of guide you through baseline data entry. I like to take the chart and the eligibility that the coordinator has put together and the PI has signed off on, and then you can open that and it really guides you to like the staging, and it shows you what they looked at when they enrolled this patient so that then data entry can follow that template. RAVE does include help boxes within the case report forms. And so this is often a really handy thing. So you see the question mark highlighted in yellow. How long has the patient been taking non-aspirin NSAIDs? You click on it and then it gives you some more information. So if greater than or equal to 6 months, but less than a year, enter 1. If less than 6 months, enter 0. So those are the type of things that you get a question like that and you're like, I'm not really sure what they want. Like, yeah, they take it sometimes, but not always. Always look for those little question marks because that can guide you sometimes in what the data managers are looking for with the data. So the baseline data forms, they'll be very disease site specific and study specific. So we're not going to get into all of those nuances here, but lymphoma forms will look very different than GU forms. They ask different questions, their staging is different, the diseases are totally different. So those baseline forms are going to look a lot different. They'll ask you about stratification factors, stage, grade of disease, prior therapies, comorbidities, et cetera, if QOLs were completed. If the form asks for prior treatments, this is something they wanted us to add in for this session. They're looking for the entire regimen and not the individual drugs. So if they get carboplatin and paclitaxel, they want that listed as one regimen versus 2 separate lines of therapy. If those drugs go together on a regimen, they just want that listed one time, et cetera. Baseline height, weight, performance status will all be asked for, and then baseline labs. Another question. The reference range of hemoglobin is 14.8 through 17.8. You enter a value of 17.7 and get an auto query stating that the value is abnormal and needs, I should have amended this. The value is abnormal. What do you do? I know Alliance trials don't use the clinically significant, non-clinically significant. Yeah, I would email the study data manager and ask about this. Or honestly, the second one, responding to the query that it's normal for your institution, I think would also totally be appropriate to respond to the query that way. But it's at some point, it looks like in this scenario, your institutional upper limit and lower limit of normal is different from whatever was put into the system. And so to clarify that with the data manager, either through responding to the query or emailing them would be the right answer. Baseline institutional contacts for the Alliance trials, there's always a baseline institutional contacts form. It's important to keep this updated. It asks for the CRA, the lead CRA, and the site investigator. And so when there are queries and questions and kind of bigger picture things that aren't a query in Rave, but like the study monitor wants to come, for example, things like that, they're going to look at this form and email the folks on this sheet. And so they want us to keep that updated. And I know it's a pain to go into every single patient and update this, but as you're in there working, if you can keep these updated as much as possible, I know Alliance would really appreciate that. Baseline AEs, again, there will be solicited adverse events. And so you'll find these in the protocol. You can find these on the data submission schedule. And so we'll need to ask our patients this when they come into clinic. So you'll always get asked these. And then the next form, baseline disease evaluation. So this is RECIST. Again, there's a RECIST session later today for solid tumor, lyric Lugano, et cetera, for our liquid tumors. But they'll ask you about disease evaluation, if they have measurable lesions. Again, the response section of the protocol will guide you through what criteria they're using and to, help you determine what you should list here as far as primary lesions, metastatic sites, etc. Where can information be found on which lesions should be reported?
Hey, Jason, can you make me a co-host while people answer this? Looks like there's some people in the waiting room.
Yes. Belen, could you do that and make Beth Moses a co-host?
Can I make who? I'm not a co-host.
Oh, I thought I made you a host. Sorry.
That's what, if you can make me a co-host, I can let people in.
Trying to do too many things at once.
Beauty of hybrid meetings.
I know. All right. Sorry, I didn't get everything. Yeah, the imaging section of the protocol, but it's called the response section of the protocol, but it essentially talks about imaging. But yeah, the response section will guide you through how to evaluate the lesions as they grow or shrink, what qualifies as progressive disease or stable disease, etc. So baseline source documentation, it'll always ask you to upload information into Rave. So often we have to upload pathology reports, radiology reports, et cetera, into Rave. And so, the pro tip here is just to make sure we're watching out for redacted. We're watching out for personal health information and make sure it's redacted. So we use Adobe Pro at our institution, where you can go in and highlight things and totally redact the patient name, date of birth, social security, anything like that from the document. Prior to us having Adobe Pro, I used a Sharpie. I mean, I would print things off, use a Sharpie, scan them back to myself and be able to upload them then. So whatever your system is at your institution, we just always want to make sure PHI is pulled off of those documents before we upload them into Rave. It is a secure system, but it's just something we need to be really careful about and make sure patient safety is in mind with that. So again, baseline specimen submission. There may be two separate forms, one for blood and one for tissue. And so again, this is a great double check of what's in biomes. So often as a data coordinator, I'll pull up biomes and see, okay, we shipped the tissue on this date, here's the specimen ID number, et cetera. So you can always look at biomes to kind of double check that. So patient status on the baseline form, it asks you what treatment they're going to go on to. Will they start treatment? Yep, they're on this arm. Were QOLs done? If they were, those will populate and you'll enter the answers, ConMeds, et cetera, and then survival status. And the instructions there say that they will proceed to the first cycle of treatment, did not complete the remainder of the form. So that's a nice thing to look for. They're only looking for that information if they're not going to start treatment. So once baseline data is done and they start treatment, then we're going to do treatment forms for each cycle. And so this, again, is pretty high level, but it's going to always ask you for what study drugs they got. So in this case, it's enzalutamide, abiraterone, prednisone. It asks for the dose level, units, dose, was protocol treatment modified, start date, stop date. So it's going to ask that type of information as you enter study drug information. So another Slido question, a patient recorded 28 tablets on a drug diary for the most recent cycle. During a monitoring visit, the monitor states that the patient only took 20. What should you do? And again, we ask these questions because of what Belen talked about. Entering data is so much critical thinking. It's not always just copying numbers from one place to another. You often get presented with these situations where you really have to think about, what is the study asking? Where could I find this information? Who could I talk to? How can I reconcile two different things? So that kind of prompts some of these questions. Yeah, so we had two right answers on this. So cross-reference the pill diary with the investigational pharmacy records. That is a great idea. Pharmacy should have DARFs, drug accountability logs, that show when patients are dispensed and return medication. Call the patient to verify. I think that's a really simple one that we can do too, to say, hey, on your pill diary, it says this. Do you remember taking pills every day at that time? It looks like it's different on our end. And just have a conversation, write a note to file, document that, write a note in your system that you spoke to the patient on this day, they verify that they took these type of pills, so that you have a good source documentation for an audit down the road. Cycles and dose modifications, it'll ask if a modification occurred, yes, planned, yes, unplanned, or no, are usually the options they give you. So yes, planned means yes, because of something in the protocol. So an AE presented itself and the protocol clearly says that if, grade 3 diarrhea, then we're going to dose reduce by 1 level. And so we modify the dose based on an adverse event. Unplanned would be something not per protocol guidelines. So a patient didn't, went out of town, forgot medicine, didn't take it for 2 days. So they did not get the right dose. Dose was modified, but it wasn't per protocol, it was unplanned, or then no. So if you select yes, a new form opens and asks why. I'm going to skip this to save a little time. Adverse events. So I thought Kim in our previous session, if you guys were able to attend that in the orientation, she did a great job with talking about adverse events, how to find the solicited adverse events, how to grade them, where to look in the informed consent. So I'm not going to talk about the same things other than just to let you know, this is a huge part of entering treatment data, is tracking those solicited adverse events and finding new adverse events that might pop up. Other adverse events. So again, after you enter the solicited, a log line, there will be an ability to add additional adverse events to the form. So, again, reading instructions is super helpful when you're entering the data. And the instructions say in this particular one we took these slides from, record all adverse events beyond those solicited, record grades 1 and 2 with an attribution of possible, probable, or definite, and then all grade 3, 4, and 5, regardless of attribution. So the example Kim gave in the previous session, if it was grade 2 diarrhea unrelated, you wouldn't need to add that to the adverse event form because the protocol said we don't need to, the instructions here in RAVE say we don't need to. But if it was possibly related, grade 2, then yes, we would add that to the adverse event form as an extra. So you notice the attribution of an AE was changed from possible to not related on an AE table, like an internal AE log form. What do? Again, critical thinking, kind of real life scenarios we see. So yeah, try to locate documentation on why it was changed. And I think I would bring it to my PI's attention to say, or treating investigators' attention to say, hey, last time, cycle 2, you said diarrhea was unrelated. Now you say diarrhea is probably related. Did you mean to make that change, or what are you thinking there? And often they'll give you a good reason to say, I wasn't sure 3 weeks ago, but now I've seen it present itself. Maybe something else is happening, and now I think it probably is related to the study drug. So again, those are some of the scenarios we find ourselves in as data managers when things don't always line up really neatly and cleanly like we'd like them to. So again, Kim talked about this, but this is just an example of an AE form that we've seen used in the past. And I think having a specific AE form for your studies that lists the solicited AEs is a really good idea to kind of take back to your institutions if you're not using a form of some kind, to be able to create, some type of Excel type form with the study and the specific solicited adverse events. It really helps the data entry process. And then in audit time, it really helps to clearly show that you assess these each time and have good documentation of it. I'm going to skip this one. Oh, this is a good one. How are labs reported? Labs are from the end of the cycle. I'm going to talk about this next, but we're going to see if you know the answer ahead of time. Labs are reported from day 1 of the cycle. Labs from cycle 2, day 1 will be reported in cycle 1, and any applicable labs out of range will be reported as AEs. So yeah. I used to think the labs were reported from day 1 of the cycle. It makes a lot of sense, but that is not how Alliance forms operate. So you are going to look at labs from day 1 of your, cycle 2, day 1 to determine if they're going to get treatment for cycle 2. But when you're entering the data, as you come to the end of cycle 1, they want the cycle 2, day 1 labs reported in cycle 1, so that then those labs, any of them that are out of range, show up as adverse events for cycle 1 because they got treatment during cycle 1, they got a blood test afterward. Anything out of range then would be an adverse event related to cycle 1, not the future cycle. So this is really confusing. I wish it weren't. But I am kind of the messenger of all the new Alliance protocols clearly say this, that they want the labs reported from the end of the cycle, not the beginning of the cycle. So something to keep in mind if you haven't done much data or seen this with Alliance, though you'll probably get queries eventually to say, hey, we actually want this. We want these labs reported on the previous cycle. And I've done that many, many times. So again, disease evaluation. So the form will ask the status of the target and non-target lesions and the overall response. Report lesions in the same order as baseline. So your site needs to have a consistent way to look at baseline. If there's a target lesion in the lung and then there's a lymph node, whatever it is, to be able to look at those same lesions as they move through treatment, because that's what we're tracking as far as if they've got stable disease, if they're progressing, if they're getting better into a partial response. We want to be able to look at the same lesions over time. So if you list it as you call it, one thing in cycle 1 and then call it something totally different 2 cycles later when they get scans again, you'll get queries from Alliance saying, we have to list these consistently in the same order and the same name moving forward so that we can track this disease at each time point. So you guys know this. Lesions should be reported in the same order as baseline. True. We're going to move fast. Survival status. Again, this form is much like the baseline one. They want to know if the patient is alive, date of most recent contact, if there was unfortunately a death, the death date, the cause of death. And then they'll ask about disease status. Was disease evaluated during this reporting period? So, you know, a lot of these trials, they get treatment maybe every 3 weeks, but they get scans every 12 weeks. And so you may say no, you know, yes to cycle 1, no, 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 and then yes again in the 4th cycle. So if you put yes, then new forms will roll out. The disease assessment forms will roll out. You'll be asked to list the lesions, but if you say no, then those forms will not show in your rave view. So again, what protocol treatment will they move on to in the next cycle, and then were QOLs done? So it's going to ask you that every time with the disease status, patient status. Again, you may need to upload supporting documentation for each cycle. So if there was imaging done, if there was different pathology, if they had a biopsy or something, that stuff will be entered. I know some Alliance trials want the treatment record uploaded. So I've seen that before. And so, you know, we've printed the treatment record from our Epic system or whatever system you use to your electronic medical records to upload into the system as well. Lab results, again, a lot of them ask for upper limit of normal and lower limit of normal. So make sure, you know, you kind of have to think about that. Think about your units and upper limit of normal, lower limit of normal. And then specimen submission. If they were collected, it asks for that. If they were not collected, it asks why. So maybe it was error at your institution. Maybe it was another reason. Patient declined, they didn't come, they didn't show up, but it will ask you for that. Off treatment. So when you select none as what protocol treatment will the patient receive next time and select none, then an off treatment form will pop up and it'll ask why they're coming off treatment. So it may be for progression. It may be they, you know, have withdrawn from treatment. They don't want to receive treatment anymore. It could be a variety of reasons, but it will ask you to specify. One thing I wanted to show was the add event box in Rave. So this is a main page in Rave. You see baseline, treatment 1, 2, 3, 4, all of the treatment cycles. So down below, there's add event, and you can click on it and choose things like lost to follow-up or second primary or new primary. So if they did, you know, go in, have a biopsy, a scan and a biopsy, and there was a new primary now, there's nowhere in the base forms to collect that, but you can click new primary and then enter that information. Alliance does want to capture that. It's important to the evaluation of their treatment, but it's not, you're not going to have to answer it every single time and say no. It just wants you to add a form when it's appropriate. So you can always look at this add forms drop down and see if anything on there is applicable to your patient. COVID-19 reporting forms. Belen, were you going to jump back in here?
Yeah.
Do you want to, we've got about 10 minutes left, so I'll let you go for it. Tell me to skip ahead.
Speed through this. So COVID-19 reporting forms, we are still reporting COVID-19 diagnoses in patients, but just if they have tested positive. So you would add it through the COVID-19 reporting in Alliance and then select what is shown in the screen. So this is just an example of what it looks like to add a patient and their information. You just want to click the pencil icon to edit the information. There's going to be an interruption and testing form, which will ask you about test results and any treatment that's received for COVID specifically. So you want to enter that information as well. And then it's going to ask if there's any protocol deviations that have happened specifically due to COVID. So you would enter that information in the protocol deviations form. Some examples of deviations that happen because of COVID are the patient having a telemedicine visit and subsequently they missed their height or weight because they weren't able to measure that at home and they didn't come into the clinic, or maybe you had missed or delayed labs or procedures due to canceled appointments. So you want to make sure that you're entering that information into the COVID-19 RAVE database for Alliance. We have one final question with Slido.
I skipped it, sorry.
That's fine, no worries. So some other tools that can be helpful for you as you're entering data for Alliance are delinquency or overdue reports. You can get this information in the Alliance website through the link that is shown here. And you can also get more reports from the data quality portal within CTSU. So you can find that in the CTSU website. If you go under the data management tab, you'll see where it says DQP, so data quality portal queries, as well as DQP delinquent reports. This is just going to give you information of, any queries that have come up for your studies that you're working on with Alliance, or maybe some of the overdue data that you have, and it further breaks it down into more detail of what is specifically pending, how long it's been pending for. And if you go towards the final page of the report, something to keep in mind is that you can just download it all into an Excel, which might be easier to look at than if you're looking at it within the actual portal.
So just wanted to plug what Belen was saying about the data status or the data quality portal reports and the Alliance reports, the delinquency and overdue data reports. Those are a lifesaver for us, at least in my institution. I try to run these every week and send them out to the team and the folks responsible for that particular study. And, I know that's something sites struggle with, is getting data in on time and just not having the manpower to do it. And I know for us anyway, it really helps us prioritize, like, what's way overdue, what's coming up due, and we can really work hard to get it in before it hits the deadline. So again, these slides should be available on the Alliance website if you guys want to look at them kind of a little bit longer than we flip through them quick, but to see about how to run those Alliance and DQP reports. We're also going to talk about this Friday morning, the CRP education session. We're going to talk more about DQP reports and Alliance reports from the website. So more information to come there, but I do think it's a really good resource. I know there's a bunch of questions in the chat. And do you want to ask me some of them?
Yeah. Someone said, if there was someone lost to follow up due to death after signing and being randomized, how do you address the pending forms?
So someone passed away after they signed consent?
And they were randomized. How you?
Gotcha, but they never received protocol treatment.
I'm assuming so.
Yeah.
That is correct. This is Meenakshi from Weill Cornell. That was my question.
Yeah, so if they never received protocol treatment on the baseline, you would still be expected to fill out the baseline forms for the patient, even if they never get treatment, whether it's due to death or whether they, change their mind on cycle 1 day 1 and don't get treatment. We still have to fill out those baseline forms because they were randomized and because Alliance wants to be able to look at that data as a patient who did have this type of disease. So they want to be able to collect that. So you would fill out the baseline forms as normal, but then in the patient status form where it says, will the patient continue on to protocol treatment? You would put no. And it would prompt the off treatment form. And then they would move into, they wouldn't move it to follow-up because they would be expired. But you would be expected to fill out the baseline data.
Thank you.
There was another question asking if there's a resource available for unit conversions of lab values. I'm not aware of one. Do you know of one, Jason?
On the Alliance website, I would have to dig around, but I know that there are some resources for unit conversion on the website. There's like a QTC calculator and other common calculators and conversion tables. And so I would look in the resources section of the Alliance website. And then honestly, I will Google stuff like that when I'm working on a chart and be able to try to convert units. And so I would just type it into a browser and Google it as well.
Are the target visit dates that are shown as due dates calculated from an anchor date, such as maybe the registration or surgery, and not the last contact?
So as far as Alliance trials go, they anchor them from the date of randomization in open, and then baseline data is due 14 days, 15 days after randomization, and then from each treatment cycle, it's that date of last contact. That's what's going to make the next form pop up. And they're going to expect data, you know, whether it's 30 days or whatever the protocol says. Usually it's 30 days from the date of the expected date. So if the cycles are 3 weeks long, they're going to give you an expected date of this date plus 3 weeks. And then they want treatment data within 15 days of that expected date, and they want follow-up data 30 days of that expected date. That's typically how Alliance looks at what is submitted on time versus what is submitted late. So they're always going to use that date of last contact as the anchor date for the cycles moving forward. And then you'll still have that 2-week buffer from the expected date to get that data submitted. Because often the date it's expected is the date they're in clinic, and we don't expect you to enter the data that same exact day. There's 2 weeks built in on that. A question from the room, yeah.
For the follow-up date, like I know they might do it from the last date they were seen.
Mhm.
Say on survival follow-up, in protocol, it usually says 6 months
Mhm.
from randomization.
Gotcha.
So does that mess up everything when that happens, or, because I definitely had confusion.
Right. And I know some of the other lead protocol organizations do this slightly differently. So SWOG and ECOG and NRG studies might anchor it from a randomization date versus an off treatment date. I think most of the Alliance trials try, and I can't guarantee that they all do this, but I think moving forward, they're trying to anchor it from the off treatment date so that you have that date in there. And then, you know, follow up is due 3 months from off treatment. And so then they would project a date 3 months, and then you would have 30 days from that date to get the data in. Does that make sense? But I know what you're talking about. And I think I've seen it with some SWOG and ECOG studies where it asks from, you know, date of last treatment or date of randomization, 6 months from randomization, 9 months. Alliance is looking at that follow or from the off treatment date anchor. Yeah.
What do you recommend to do when rave, when the date in rave is inaccurate?
When the data in rave is inaccurate?
Date, the due date.
Oh, yeah, that's tough. I would do your best to enter the information you can by the date that it says in rave. But the reality is if the patient got delayed per protocol and they have not gotten treatment yet for the next cycle, then we can't close up that cycle. So we can't enter all the information. So I would just put a pin in it and put a note on your calendar to check back. You know, if it's Tuesday and they're coming in, they get delayed a week to next Tuesday, you know, put a note on your calendar to check back and check back. Sometimes patients get delayed multiple weeks in a row, and that's part of it. And Alliance understands that. And they've told me before that, you know, late data due to patients being delayed would not count against your institutional performance score. It wouldn't count as a negative on an audit because they can see why this data was entered late, because there was a specific reason why the patient didn't come in on that target date. You know, I don't know how sophisticated that system is. It's going to show it as overdue, which drives me crazy. There's no real way to get that date to not say overdue, even though you've got a very good reason. So, I mean, that would be my advice, is to put a pin in it, put it on your calendar, make sure you get it in as soon as you can once the patient does come in, and either start the next cycle or maybe they come off treatment when they come back, whatever the case might be. But that would be my best advice. There's really not a great way to be able to tell the system, hey, this patient's delayed and they went on vacation and now they're a week behind. There's no way to tell the system that.
I have
Glenn?
one more question for you. How do you know what cycle to document the end date of the AE? Is it in the cycle or reporting period when it ends, or do you go back to the CRF where you first reported it?
You would document the end date in the cycle that it ends. So if, you know, grade 2 vomiting started in cycle 1, you would put a start date in cycle 1 and there wouldn't be an end date. It would carry forward. And then in cycle 2, that start date would be the same as the previous start date. There would be no end date. And then in cycle 3, Great. The nausea medicine starts working. They stop vomiting. Great. Then you can put an end date in cycle 3, and it should reconcile itself within the system. You don't need to go back to cycle 1 to put an end date. You can leave that one open, so to speak. But as long as the cycle it ends in has the end date, that should be what the system is looking for. Well, we are a couple minutes past. I want to let you guys get to the next session or wherever you're headed. So thank you so much for your time and attention.